If you work in emergency care, you've seen precipitated withdrawal after naloxone. It's awful. Buprenorphine can cause the same reaction if it's given in the wrong context. Bup and naloxone withdrawal look a lot alike, but understanding the difference is key to managing it correctly. Naloxone causes precipitated withdrawal because it's a mu receptor opioid antagonist. It kicks opioids off the receptor and doesn't replace them. That leaves the patient with a sudden drop in opioid signaling, which then initiates withdrawal. Buprenorphine is a partial high-affinity agonist. So if someone is already in withdrawal, the partial opioid receptor activation helps them feel better. But if the opioid receptors are still saturated with a full agonist like fentanyl, buprenorphine will push it off the receptor without fully replacing its effects, meaning withdrawal pathways activate and symptoms kick in fast. The good news? Precipitated withdrawal is treatable. And the treatment is? More buprenorphine. The idea here is to saturate those receptors with enough bup to stop the signals of withdrawal and eliminate the possibility of lethal overdose. Current recommendations start with 16 milligram inductions. But if your patient experiences precipitated withdrawal, immediately give another 16 milligram dose, followed by 8 to 16 milligrams every 30 minutes until symptoms stabilize, usually topping out around 32 milligrams. And don't forget to treat symptoms, which not only improves comfort, but builds patient trust. Now, you've all heard that giving buprenorphine too soon can cause precipitated withdrawal, especially in settings where use history may not be accurately reported. And even though it's rare, it's important to gather as much history as possible to help prevent patient discomfort. Relying on objective measures like the COWS can help guide your assessment. High-dose guidelines advise waiting for a COWS greater than 8 in order to reduce the risk of precipitated withdrawal. And depending on your patient and your practice setting, there are alternative protocols and microinduction strategies that can support an earlier start. And if your patient recently used fentanyl but is in withdrawal precipitated by naloxone, buprenorphine is an excellent treatment solution that will both treat their symptoms and reduce their risk of repeat overdose. Precipitated withdrawal is not a buprenorphine failure. It's a signal to lean in with more medication and supportive care. Done right, you can transform a tough situation into an opportunity for recovery.